My second case presentation is on Cvid. My patient was a 58-year-old Caucasian male with the chief complaint of painful ulcers all over my mouth for 2 years. His pain was 3 out of 10 at rest, 5 out of 10 at function, and 7 out of 10 with spicy food and VAS. Since February of 2009, he's been experiencing burning sensation of the left lateral tongue. Excisional biopsy was performed, and the report said it is consistent with lichen planus. The pain was persistent. Fluocinolone gel was not very effective in managing the lesion. In November of 2010, left buccal mucosa was biopsied and was diagnosed reactive proliferation of capillaries with surface ulceration. Then in March, his dentist prescribed him the magic mouthwash, and of course it was not helpful. In April of 2011, excisional biopsy of right tongue neoplasm was performed. It was actually quite big in the excised size, 5 cm times 2.5 cm. But the result was just an ulcer and granulation tissue. I suppose treating doctors suspected something else must be going wrong, and the slides were sent to University of Michigan. But again, the result was chronic ulcer with adjacent lichenoid and acute mucositis with candidiasis, and it was negative for neoplasm. Then there was a big turn of event. In October, he developed a full-on chickenpox. 58-year-old men should not be getting this, and therefore was tested for immune function. And finally, he was diagnosed of CVID, or common variable immunodeficiency. When he first came to our clinic in February, he has already tried fluocinolone, magic mouthwash, and diflucan, and they didn't help with his condition. He has hypertension, hypercholesteremia, constipation, and alopecia. No allergies and no history of recurrent infection. However, his serum IgG level was significantly low, so he was receiving series of IVIG, and it was starting to reach the lower border of normal range. When he first came to our clinic, his mouth looked like this. As you can see, there are large bilateral multiple ulcerations on the tongue and buccal mucosa. They were sensitive, and the patient could not tolerate spicy food and also had blunted taste and sweet. Our differentials were lichenoid mucositis, benign mucous membrane pemphigoid, pemphigus, and paraneoplastic pemphigus. These lesions did not seem like a malignancy, and it was already ruled out by past 2 biopsies. Fortunately, previously seen doctors did not know that the patient had CVID, but we did. So, with the law of parsimony, we suspected that these 2 conditions may be related. Treatment regimen was the same as any other autoimmune-mediated ulceration or visculobulous lesions of the mouth. However, we started with clobetasol because the patient told us that his lesion did not respond to fluocinolone alone. We didn't put him on systemic corticosteroid because of his underlying immune suppression. Misylextroki was actually called in afterwards because he sent us a photo of his mouth covered with white plaque. We should have prescribed this from the beginning because he was immunocompromised in the first place, and we should have expected this to happen, and should have prescribed misylextroki as a preventative. This is how his mouth looked on the second visit. It was approximately a month after the first visit. As you can see, there was a significant response from the treatment which the patient was very happy with. We performed biopsy on this day from this site, both immunofluorescence and H&E stain. This was the biopsy report. As we suspected, it did not have any abnormal immune complex deposition, and it was just an ulcerated lichenoid mucositis. The diagnosis: ulcerated lichenoid mucositis with the findings of heavy influx of primarily chronic inflammatory cells with rich vascularity and underlying connective tissue. Moderate to high irregular deposition of fibrinogen at the basement membrane zone and at the surface consistent with an ulcer. IgG, IgA, IgM, C3, and fibrinogen all showed appropriate immune complex deposition. It was important for us to perform immunofluorescence because none of the studies of oral lesions of CVID performed it. And it was important for us to see if there are any difference between normal lichenoid mucositis and an oral manifestation of CVID. So, this is his last visit to our clinic in the end of May of this year, approximately 3 months after the first visit. There are a few areas with deep remaining ulcerations, but most of the ulcers were healed. So, let's compare the photos. This is the first visit of the right lateral tongue, and this is 3 months after. This is the left side of his tongue, and this is 3 months. Buccal mucosa, looking very healthy. And on the other side, it looks very healthy too. Although he has only used fluosinonide in the past, we can't conclude that our corticosteroid regimen was the only thing that helped him. What probably helped with his healing was both IVIG and stronger topical corticosteroid therapy with antifungal medication. Oral manifestation of the systemic disease always reflect the severity of the underlying condition, like paraneoplastic pemphigus. We do think IVIG was also an important factor to his response to our treatment. So, what is CVID? It stands for Common Variable Immunodeficiency. CVID basically is a failure of B-cell production of immunoglobulin. It is actually the most commonly encountered and clinically relevant primary immunodeficiency in adults. CVID was first described in 1953 by Janeway et al. And the term coined by Cooper et al. In 1973. To be diagnosed as CVID, IgG must be decreased at least 2 standard deviations below the mean for age, and also a marked decrease in at least one of the isotypes, IgM or IgA. And to be strict, there is a criteria that needs to be filled. 1. Onset of immunodeficiency at greater than 2 years of age. 2. Absent isohemagglutinin and or poor response to vaccines. And 3. Other causes of hypogammaglobulinemia should be excluded. Immunoglobulin is like a bullet that our body produces to kill invaders. It is released from plasma cells differentiated from B cells. So, B cells or plasma cells are like these guys, but shooting at invaders of the body and not you. If this system is somehow not working, there are several complications. One is recurrent infections. This is not hard to imagine because basically the patient is immunocompromised. Recurrent respiratory tract infections are the most common symptoms, occurring in up to 98%, followed by acute otitis or chronic sinusitis. In rare occasions, mycoplasma infections may destroy the joint, or enteroviral meningoencephalitis or ureaplasma infection of urinary tract may occur. Another complication is GI complications. This is probably caused by diminished IgA, which is another commonly diminished immunoglobulin in CVID. And IgA normally works to protect the mucous membrane of GI, including oral cavity. So, transient or persistent diarrhea is commonly seen from 20 to 60%, as well as chronic gastritis. Nodular lymphoid hyperplasia may be present, granuloma, lymphocytic colitis, and because of these gastritis or diarrhea, pernicious anemia may also be seen. Interestingly, although immunoglobulins are diminished, autoimmunity is the next common complication involving 25 to 48% of the patients. Most of these cases are autoimmune cytopenia, such as hemolytic anemia, neutropenia, or thrombocytopenia. However, other autoimmune conditions may also be seen, and in this patient, alopecia was present. The most scary part of CVID is increased risk of malignancy, especially gastric carcinoma and non-Hodgkin's lymphoma. For gastric carcinoma, 7 to 16-fold risk. This is probably due to a Helicobacter pylori infection, which is commonly seen in CVID patients because of immunodeficiency. Non-Hodgkin's lymphoma is also increased to 12 to 18-fold. And most of the times it is extranodal B-cell origin and Epstein-Barr virus negative lymphomas. So, what are the oral manifestations of CVID? And this is where we were most interested in. But oral manifestation is actually not well documented. And this is actually why I'm trying to publish this case. But oral candidiasis and minor aphthous stomatitis are commonly reported symptoms. For oral candidiasis, 26 to 32%, and aphthous stomatitis, the minor ones, 38 to 60%. But not the major ulcerations like we saw in this patient we had. So, who gets it? Prevalence is reported and range from 1 in 10,000 to 1 in 100,000. However, many are thought to be underdiagnosed, and this number may be a little more higher. It can be seen in both gender and commonly diagnosed in 20s to 50s from unusual recurrent infections, and our patient was in 50s. Etiology of this condition is not clear, but it is thought to be genetically induced, and 10% are seen in familial clustering. Other genetic markers have been researched. CD19 complex mutations or deficiency are the most well-studied markers. It is a glycoprotein found on B cell, just like CD4 and CD8 on helper T cells and cytotoxic T cells. CD19 and CD21 are B cell specific antigens, which act as a co-receptor when recognizing an antigen. Others I will not go in details, but mutations of these receptors or genes are found in patients with CVID. CVID is treated with IVIG, 400 mg per kilogram per month, and target serum Ig level of 800, 700, or 650 to 1000, depending on which recommendation value you use. The patient receiving IVIG has significant decrease in incidence of developing pneumonia. Unfortunately, we don't know its efficacy to an oral lesion. Other options are immunomodulators such as rituximab or stem cell transplantations, but there are not much data on these treatments yet. Due to the multiple complications such as recurrent infection, GI complication, autoimmune reaction, and increased risk of malignancy, survival rate does significantly reduce compared to healthy individual. 23% mortality rate at 7 years was reported by Cunningham and Wundels, and 20-year survival rate after diagnosis of CVID was significantly lower in both male and female. There was another study reporting 30% mortality over 25 years. So, that concludes my presentation. Thank you very much for your attention.